Center for Advanced Parotid and Facial Nerve Surgery. Today we're doing a live question and answer session on salivary gland and parotid issues specifically. So we have a few questions that have come in. I'm just going to go ahead and start with those questions. The first question is from Cynthia Dudzinski. Hopefully I didn't murder the name. In any case, would all sutures used be self-dissolving even when a deep lobe parotid tumor is removed? They should be. Let me show you. So when I do a deep lobe tumor removal, let me find that example for you. So there we go. So if you have a tumor that's deep to the nerve, so on this image, you can see the facial nerve coming and superficial, and the tumor is sitting deep to it, right? And the cross-section view of it is that you have the tumor that's deep to the facial nerve, the white line being the facial nerve, and anything superficial to that we call the superficial lobe, and anything deep to it we call the deep lobe, right? So when I have a tumor that's deep lobe, at first I have to open the area and find the nerve, right? If the nerve is immediately touching the tumor here, right? If the nerve is sitting, I'll draw that nerve, and touching the tumor, then I have to actually transpose the nerve in order to be able to take out the tumor, right? Very gently so that we don't cause any bruising or swelling. And the size of the tumor matters. The smaller the tumor, the less movement you're going to need from the nerve, right? If there's a distance between the nerve and the tumor, then you don't have to necessarily move the nerve. You can just get underneath it. Anyways, once this deep part is removed, I have to do a reconstruction. And I generally do that by using absorbable sutures on the deep side, which you can see both here and here. And then I'll use absorbable sutures on the surface to put everything together, right? And then I use 2 layers of sutures under the skin here at the incision in front and behind the ear. And all of them were absorbable sutures because there's no need to use a permanent suture in this particular area. There's no advantage to that. Uh, and so, yes, all sutures should be absorbable and dissolve in time. We have really good, strong sutures that can stay for a period of time before the body absorbs and resolves them. So it can be done very safely. Peter is asking, is it safe to have a core biopsy of a parotid adenoma, and how often will it cause seeding? Well, um, it is entirely safe to do a needle biopsy. Let me see if I have the slides showing that, the difference between the two. There we go. So the difference is this. The needle for a needle biopsy is thin. You can see that thin line, while the caliber of the core biopsy is much thicker, right? And the needle just has if you look at the needle, it looks as a hollow bore of the needle, right? So once you go through the tumor, little cells will accumulate inside the hollow bore, and then you take the needle out and these cells are within the needle. Core biopsy, it works differently. So if you were to magnify this, what you would see is that the core biopsy needle has 2 components. It has it has an outer sheath. Let's do it in white for continuity, right? So it has an outer sheath, much bigger caliber than a needle biopsy, right? And then it has an inner component. The inner component has a part that comes and looks like this, which turns into a sharp tip, right? Right. So when you put it in, this portion, which is from here to here, goes into the tumor, and then you put the sheath over it. So the sheath comes this way and covers it, right? And so then what you have is essentially this much specimen sitting inside the covered sheath. But as the white covering is coming forward, it can amputate some tumor cells, and these tumor cells can sit on the needle. And as you withdraw it, it can drag it along and seed other places. I don't know if there's clear percentages um, on that. What percentage? I just know that there have been reported cases of seeding with a core biopsy, and there have been none with a needle biopsy. And this is the anatomy of the whole thing, the engineering of it all. And so it makes sense. So do we do core biopsy? On occasion, we do, right? Well, we don't know if it's an adenoma, right? If we knew it was an adenoma, then you wouldn't need a core biopsy. But if you have a needle biopsy that gives you no, unclear answers, and you really need a clear answer before you go into the operating room, right? And that is uh, as if let me give you some of the scenarios. In terms of lymphomas, needle biopsies are too thin and small to be able to get enough cells from the lymphoma that's inside a parotid gland to give a clear answer. So when it comes to a lymphoma, a core biopsy is appropriate, and seeding is not a concern as it relates to lymphomas, because lymphomas are generally spread to multiple lymph nodes, and the treatment is either chemotherapy or radiation and not surgery alone, typically speaking. So seeding is not an issue with a lymphoma. But with a pleomorphic adenoma or parotid cancer, seeding is a consideration. So if you have a small tumor that looks exceedingly suspicious, perhaps it's causing pain or paralysis of a branch of the facial nerve, and your needle biopsy is not able to tell you what it is, and you need to know that in order to plan your surgery or plan a facial nerve reconstruction, then you may proceed with a needle biopsy, with a core biopsy to get more information, knowing that you may have to do a more extensive surgery after the core biopsy is done, because you may have to clear out the tract where the biopsy is done for. So you have to have a good reason. Generally speaking, we try to avoid it, because the alternative is if you have a tumor that looks like a pleomorphic adenoma, right? On your ultrasound, on your scans, on the history of its development, took 10, 12 years to grow from a little peanut to the size of a golf ball, let's say, then you really don't necessarily need to do a needle biopsy of that, or do a core biopsy if your needle biopsy is not telling you what the tumor is. During surgery, once you've removed that mass, you can send it to the pathologist right then and there, and they can tell you if it's a pleomorphic adenoma or something else, and you can act on it. And that requires a conversation with the patient, right? To say, hey, this is what we're going to do as an alternative to a core biopsy because it does look like a benign tumor, right? And based on what we find, if the pathologist is able to tell me that this is a benign tumor, great, we continue as that. If the pathologist does not uh, tell you, or if the pathologist says that it's a cancer, then we deal with it appropriately. We do a cancer operation. Okay, so that conversation with a person who's going to have the surgery is really key because you can inform them and have them follow your give you a set of clear directions as to what they wish to have done, right? If you find yourself in a position where there's a cancer to deal with, and then you have a clear path forward. And that is not a bad way to go, knowing that there is less information on a needle on a intraoperative pathology report because it's just a simple cut and a simple look. They don't have time to do special staining, and but it does give you a lot of information, and it may give you information about the periphery and so on and so forth. So there's a lot to be gained by doing an intraoperative pathology report as well, and that's an option instead of a core biopsy, right? Because the core biopsy can seed tumors. Hopefully that's clear, Peter. Leslie Ann is asking, my left parotid gland is over twice the size of my right one, I'm assuming, by CT scan and palpation. I have intermittent pain in my cheek, teeth, jaw, and palate on that side. Doctor feels it is benign from the CT. That could very well be benign, meaning that it's not a cancer, but obviously it's not functioning properly and it's diseased, Leslie. He's not advised any further treatment. Do you have a recommendation on what to do at this point? Okay, yes. Let me get to parotid enlargements and find the pictures for you. So when you have a cross section of the face, this is the cross section of the face. In this area, you can see all the upper teeth, and this is the jawbone, and this is the parotid gland, right? This is a normal parotid gland, and this is an enlarged parotid gland. So, what are the causes of parotid glands getting enlarged? Well, one cause could be that if you were to look at the ducts that go from the gland into the mouth and bring the saliva out, as you go in the gland, the ducts get multiple branches, right? Let me show you. Fine. There we go. So this is the ductal system here going into the mouth, and the blue line is saliva coming into the mouth. If anything causes narrowing of the ducts, right, as you see here, you have narrowing of the ducts, then not all the saliva can get out, and some of the saliva, instead of going out, backs up in the gland, and over time, that causes the gland to get bigger, bigger, and bigger. All right, so obstruction can be a cause of this problem. So I encourage you, Leslie Ann, to see an ear, nose, and throat doctor who works on parotid issues, right? There is a procedure called sialoendoscopy. Sialoendoscopy, where we put a camera into the duct, right? And we see if there's any narrow spots and we stretch it open for you. So that's one option. It's possible that if you're not hydrating well, right? So let me bring this up. So, the saliva glands are producing a lot of saliva that comes through the ducts into the mouth, right? If you're not hydrating enough, then what could happen that is that if you were to imagine these ducts, when they go in the gland, they divide up into main branches and then millions of microscopic branches, right? And the saliva, generally speaking, is going through these branches and then coming through the mouth. So from all the parts of the gland, you're getting saliva coming through, right? So if you don't drink enough water and you're dehydrated and your saliva in the gland is thicker and more gelatinous, it can get stuck here in multiple areas. So the next time you're making saliva, instead of it going through, it backs up into the gland, right? And when it backs up in the gland swells up and gets bigger and bigger, right? Generally speaking, at the beginning of this process, what happens is that every time you eat, the gland gets bigger for a few hours, and then the body absorbs that excess saliva, and then the gland gets smaller. And as this process goes on, you get more and more of this swelling of the gland, and it stays with you longer. And then at times it gets infected and becomes more problematic, and the problem continues, right? So it can be from dehydration, it can be from a stone forming. So sometimes people have stones forming. Let me show you. So if the sediment in the gland, because of dehydration, builds up, it can come together and form a stone right there, and then the saliva can't get up and backs up in the gland, and the gland gets bigger. So let's look at that again. So Leslie, since you've done a CT scan and it hasn't shown a stone, unlikely that the stone is your issue. So you either have narrowing of the ducts, right, causing your gland to swell up, in which case I would encourage you to increase your hydration, put a heating pad on the parotid gland for 5 minutes, and then massage in an upward and forward direction for 5 minutes to see if you can get any of that thickened saliva out of there. And by doing that, if you can get the gland to function properly. This may take a month of you doing this regularly to get you there. Try that, right? So we know you don't have a stone. Try this technique. If this works, great. If that doesn't work, then either you have too many blockages in the gland, in the ductal system, and it's never going to open up, in which case you need your parotid gland removed, or you may have this condition called sialosis, right? And sialosis causes one or both parotid glands to get bigger, right? And the treatment for that also is to remove the parotid and reconstruct it so that your face is even again instead of ballooned out. And those are the steps I would suggest. It's a little bit of a tough issue, but be persistent. You'll be able to get some results. Hopefully, there's a good chance that you may, and that way you can avoid surgery. All right, my dear. Good luck. Gabby Valenzuela. Does parathyroidectomy cause Sjogren syndrome? No. Sjogren syndrome is an autoimmune disease. It means your immune system by mistake attacks your body. So parathyroid surgery, which is a tumor in the glands, in the hormonal glands next to the thyroid, doesn't cause it. Parotidectomy, removing the parotid, also doesn't cause it, right? This is an immune mistake. It's not a weakening of the immune system, but rather an immune system that's making a mistake and thinking your salivary tissue is foreign tissue and needs to be attacked. Okay, good question. All right. MS Trivet is asking, I have a pleomorphic adenoma and it was surgically removed in May of 2021, but it came back in 2023. So it was incompletely removed and a portion of it was left behind that grew. So I had another surgery in January of 2025 and it was also the same tumor, reoccurring, of course. Thankfully, it's still benign, yes. But do I need to do anything for the tumor not to come back? Also, one of my cervical lymph nodes has been swollen for the past 6 months, but my doc says nothing to worry about. What are your recommendations? Well, let me explain. So pleomorphic adenomas are odd because they have an imperfect capsule. So when you look at this is a pleomorphic adenoma tumor, right? Once taken out. If you were to look at the cross section of the pleomorphic adenoma here, you would see that it has a capsule that's thick at times, thin at times, absent at times here. And it can have bulges in there, which is what gives you this lobular formation. It can have these finger-like projections, right? And so if the surgery is done in a fashion where it's too close, it can cut these legs and this can grow into another tumor, right? So if you cut multiple legs, right, you can have multiple tumors, okay? More often, the problem is that these tumors may have too many gaps on their surface. So anywhere between 4% to 30% of the surface of a pleomorphic adenoma may have gaps. So if there is a lot and you have multiple gaps together, right, close to each other, as you're trying to remove the tumor, that tumor may rupture, right, break open and spill cells. So the reason I'm saying this is that the pathology report on your first operation is important to see if your margins were positive, meaning when they took it out, did they see tumor coming all the way to the edge of what was removed, right? Which may mean that there's a little piece left behind on the other side, okay? Or if there was rupture of this tumor, right, which could have caused spillage of multiple cells. The second pathology report is important for your surgery in January of this year because if they took out an extensive amount of parotid tissue, right, and they only found one parathyroid there, then I'm sorry, if they only found one pleomorphic adenoma there, then that's good news because it probably means there wasn't spillage, widespread spillage, and you don't need to do anything else. I would do a scan every 2 years for the next decade to see if there's another recurrence. Now, if, on the other hand, if they, on the second surgery, when they took it out, they found 5, 10 pieces of pleomorphic adenoma, then it may mean that after removal, multiple pieces were left behind. Let's see if I have a picture. Right, so like in these scenarios, okay, where this person had multiple pieces, right? So these are the visible pieces. Is it possible that in addition to these, that the person has multiple tiny microscopic pieces that weren't removed, right? So this portion was removed, right? And then there was 3 more microscopic pieces here, here, and here that weren't seen on the scans and were outside of the area of what we were operating on. And if you give them enough time, they in time will grow and show themselves, right? So again, on the second surgery, they found 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, for example, pieces. You can almost bet that there's probably more pieces. In that scenario, I always recommend a radiation treatment, all right, to take care of any microscopic pieces. There isn't anything per se that you can do to prevent it outside of making sure your immune system is strong, because your immune system recognizes pleomorphic adenomas as being something not wanted and has the potential of trying to get rid of it. You can't bet on it, but I would personally take the path of trying to get myself healthier and in a better state so that my immune system is stronger and potentially can take care of it. And I would repeat scans every couple of years just to make sure I catch these if they come back at an earlier stage. Okay? Good luck. Sarah Jane B. If you don't get clear margins but it's confirmed benign, do you recommend any follow-up treatment or just monitoring. I, 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 so there was a study done years ago for pleomorphic adenomas where they took out this doctor, amazing doctor, Dr. Robert Witt, went and looked at the specimens in the hospitals of pleomorphic adenoma, looked at all of them, and found that all of them had a positive margin, right? Even though a great majority had been read by the pathologists having a negative margin, on revisit and re-examination, all had positive margins, right? And despite that, only 3% recurred, right? So this tumor actually has a relatively low chance of recurrence, right? Despite being so prevalent. It's and so probably the just having a small microscopically area of positive margin is probably doesn't give you a high chance of recurrence, right? So because of that, so if only 3% are getting a recurrence when 100% had positive margins, then you really don't need to go overboard and treat someone who has a small area of positive margin, a microfocus. I'm not talking about an amputated piece of the tumor left behind, right? Where you can grossly see it. I'm talking on a microscopic level, right? So you don't need to do anything else. I would, for all my patients, I recommend that they do a scan, an MRI at 5 to 7 years after surgery, just so that if there is a recurrence, that's how long it's going to take for a microscopic small piece to grow large enough to be visible, right? So I try to encourage my patients, all of them who have pleomorphic adenomas, to do a scan. Now, if you have a bigger area of positive margin, then I would do it sooner rather than 5 years. Okay. Uh, and there is no real treatment for it. I wouldn't recommend doing radiation for a positive margin on a benign tumor, right? I would recommend it for recurrences, just like we described. Okay. Hopefully that helps, Sarah. Okay. Niyamatullah Nasimi. Hopefully didn't mispronounce your name badly. How is the prognosis of carcinoma ex pleomorphic adenoma? I had a lump since I was a kid, but unfortunately they didn't do anything as it was a pleomorphic adenoma, and it turned to be cancerous now. The tumor size was 4 centimeter, while the cancer was 2 centimeter. Okay, so very good question and a very important question. So when pleomorphic adenomas transform, right, they can be obviously very aggressive and concerning. Um, but the transformation happens from one cell inside they're transforming into a cancer. And that one cell turns into two, and two cells become four, and then it grows and grows and grows. If you catch a carcinoma ex pleomorphic adenoma at this stage where it's contained within the gland, then surgery alone is enough. If you catch it here and you're able to get a good margin around it, that may be okay. But when it's widely coming out of the pleomorphic adenoma and into the parotid tissue, then the prognosis is more challenging. And what needs to be done is chemotherapy and radiation, or potentially immunotherapy, if we find markers for it, specific markers uh, for doing this, right? Um, Now, the other thing that is important in terms of pleomorphic adenoma is what type of cancer it has turned into, right? So it can turn into adenocarcinoma, right? Right here, epithelial myoepithelial carcinoma, and salivary ductal carcinoma. whichever type of cancer it has turned into, right? The treatment is based on that type of cancer. So salivary ductal carcinomas are very aggressive. Adenocarcinomas of NOS, not otherwise specified, can be very aggressive. Epithelial, myoepithelial are less aggressive, right? And so based on what type you have, the treatment is catered to that and the prognosis is changes. So the size and dimensions being within the pleomorphic adenoma or eating through the pleomorphic adenoma and coming out. So if you say to me the tumor was 4 centimeter, but the cancer was 2 centimeters, it's possible that the cancer, right, if this was your pleomorphic adenoma, it's possible that the cancer is this big and well within the capsule, hopefully, in which case your prognosis is excellent. All right, very good question. This is the reason we encourage everyone to remove a pleomorphic adenoma, especially if you have it as a child or when you're young, right? If you have more than 10, 15 years of life ahead of you, right? So if you're 50, 60 and you have a pleomorphic adenoma, I suggest you remove it. If you're 85 years old and you have heart disease and lung disease and your life expectancy is not necessarily 10, 15 years, then you may observe it. So observing a pleomorphic adenoma in a younger person, by young person meaning 60 and younger, and even older than 60-year-olds or healthy still should have that removed. Okay, let's answer some of the more questions that have come in. Let's see here. Cynthia Dudzinski, after a year and a half of having deep lobe pleomorphic tumor removal, I'm still feeling sensitivity just under the ear. Oh, so Cynthia, that probably is because of the greater auricular nerve. So let me show you that anatomy. So this is the greater auricular nerve. This one right here. Let me do it in black so it's clear. It comes up and gives you branches to the skin over the parotid, to the earlobe, and the skin around the ear, right? And so if during surgery this nerve is cut because of this modified Blair incision, right? They cut this nerve there, then the nerve can give you phantom pain. It can, as it's regrowing, it can give you tingling and uh, that feeling that you get when your arm falls asleep and then you straighten it and it starts to tingle. So all of that could be because of this nerve, not necessarily because of the parotidectomy or the parotid functioning differently, okay? Because it is more likely this great auricular nerve that was affected, okay? Cheryl Neckrick Weiner. I had a pleomorphic adenoma in both of my parotids and submandibular glands removed separately a few years apart by 2 different surgeons and was left with a Frey syndrome. What type of doctor treats this? I've had Botox treatment many years ago, but the doctor is no longer practicing. Well, Cheryl, any ENT should be able to give you the Botox treatment, right? To prevent Frey syndrome. The alternative is to do a surgery where you put a barrier between your skin and the parotid gland, the remaining parotid gland, and that can stop the Frey syndrome as well. It is exceedingly rare for people to have multiple pleomorphic adenomas and in multiple places. There is a gene called FLAG1. FLAG1 gene. Pleomorphic adenoma gene 1. And this can run in families. The reason I am letting you know about this, Cheryl, is that if you find that, if you do genetic testing and you find that you have the mutation in this particular gene, then you can let your siblings and your children know to be very hyper vigilant and look for this. The other thing that could cause it is high dose radiation exposure, but I've never seen a person get it in all of their salivary glands with radiation, right? So more than likely you have a genetic predisposition to this thing. So please look into that as well. All right. Liz Williams, what could cause my head to feel like it's in a vice and my head goes numb on the side? I have two tumors removed 4 years ago. Very uncomfortable. Um, I mean, if you had tumors removed on one side, then you shouldn't be feeling discomfort on the opposite side. If you're feeling discomfort in the temples on both sides, more than likely that's happening because this muscle here called the temporalis muscle, it comes and it goes like big circle here, right? That big muscle is in charge of biting down, right? So if you're grinding in your sleep or you're clenching your teeth in your sleep, these muscles are working hard and they may feel constant pressure, right? So look into that. Look into temporomandibular joint problems or TMJ or teeth clenching and grinding, which could be the source of it. If you're feeling this vice experience on both sides, because surgery on one side shouldn't cause that to happen on the opposite side. Okay. Now, if you're only feeling it on one side, on the side where you had surgery, then that could be a nerve related issue, right? And you should see your surgeon and talk to them about that and see if they have any way of treating it. There are medications to control the nerve overreactivity, including Elavil and gabapentin and so on and so forth. So there's remedies for it. Definitely look into that. Okay, that looks like all the questions we have here. Oh, hold on. Let's see. There are questions about another illness called hyperparathyroidism. All right. So this session is about parotid disease, not parathyroid disease. So there's a few questions about parathyroid issues. Um, we can address that on it separately from here. In any ways, hopefully this is helpful. Yeah, these questions were amazing, actually, very good questions, and that delved into a lot of important subjects. If you have any further questions, don't hesitate to contact me or visit us at our website, parotidmd.com. There's a lot of good information on that site as well. But you can come on our any of our social media outlets and ask questions, and I'll do my very best to get to them and answer those questions. I hope you have a wonderful day, and I hope this session was helpful. Be well.